with a special emphasis on additional training in cultural awareness as public health principles and healthcare disparities. And so the two inaugural members of this track are Dr. Salah Abdelgadir and Caitlin Will. And so I've invited them to give a presentation this morning on sort of a case series on social determinants of health from their home culture. And so what the point of this additional training is to sort of build a toolkit that the residents can use to sort of better impact the health of the communities and the populations in which they serve. One of the clearest ways and starting points for understanding what are some of the social determinants of health is to look at your own culture and tell a story based on your own experience. And so these two young doctors will present those this morning, and you'll see that they're very different stories, and that is in some ways intentional as a way to kind of help illustrate the fact that these skill sets, this bit of understanding can be applied whatever community you find yourself in, if you stay here in Chattanooga or you end up on the ends of the earth. So thank you guys for coming. Please feel free to eat plenty of the breakfast. There were no pumpkin seeds involved in the baking at Need Loves over the past 2 weeks. With that said, I think we'll be starting with Dr. Abdelgadir. So welcome him, guys. Thank you. Oh, one last thing. Between these two presentations, we'll have time. We'll just move from one to the next. You can save your questions and comments for the end. Thank you.
Good morning, everybody. My name is Salah, and I went to medical school in Sudan, so I'm going to be talking a little bit about that, and we can start with the case. So let's just get into it. So this is a 67-year-old Caucasian male. Presented to a hospital with rapidly progressive cognitive deterioration, an unsteady gait, urinary incontinence, and increased somnolence. He stated that his symptoms started around 10 months prior to presenting to the hospital. He reported several instances of some memory problems, such as unable to find the care home for his mom, which he frequently visits. He was trying to get there one day, he said, and he got lost. He also says he's becoming irritable and developed balance problems, falling once in his garden. And he stated that his symptoms started to progress more rapidly over the prior months to presenting to the hospital. The only past medical history that he reported was having type 2 diabetes and hypertension, past surgical history of an inguinal hernia repair, and he's only on metformin and an ACE inhibitor for his past medical history. He's not allergic to anything. He's not a smoker. He only drinks on social occasions. And he has no history of IV drug use or anything like that. A review of symptoms showed a confused gentleman with an unsteady gait, incontinent, short-term and long-term memory impairment. His vital signs were fairly stable. His temperature was around 100 Fahrenheit. Blood pressure was normal. His heart rate was in the 90s. His respiratory was around 16, and he was sitting on room air 92%. Physical exam, he was confused, drowsy, was variable GCS. 7 to 14, his head was normal cephalic atraumatic, pupils were equal, round, and reactive. No sinus tenderness on exam, regular rate and rhythm, S1, S2 were heard, and he had no murmurs, rubs, or gallops. His chest was symmetric, non-tender to palpation. His breathing, we were equal and clear bilaterally, and he had no wheezes, no rhonchis, or rales. Abdomen was also non-significant, soft, non-tender, bowel sounds were present. There were no masses palpated, and he had no CVA tenderness. Extremities, his pulses were intact. He was not cyanotic. He had no clubbing or edema. What was significant is that he was confused. His AMT score was 1 out of 10. He was apraxic more on the left side than the right. He was ataxic with global hypertonia, hyperreflexia, and with no sensory changes. Skin was warm, diaphoretic, and no rashes, So differentials. Do you guys want to go back?
Falciparum, malaria. Is it a waxing and waning course, or no, this is a gradually progressing course?
Yeah, it was just a gradually progressive course in the past 10 months. Any questions?
What's the setting? Is this Sudan or is this
This was actually a case report from England.
England?
Yeah,
So this is happening in England.
this is happening in England.
Differential could include NPH.
Okay.
So when you go to England, they ask if you've been to a farm, they worry about CJ disease or prion disease.
Yeah. So he's a photographer. That's his profession.
But he could go all over taking pictures.
That's fair. Yeah.
Where has he traveled?
Yeah, he has.
Where?
He goes to Asia, he goes to Africa. He's kind of that kind of photographer. He was in Ghana around 4 years ago, he stated. He recently had a trip somewhere in Malawi in the past year. You guys want investigations?
Yes, we do. We want
Okay.
those.
CBC was normal. Platelets were a little low. His BNP was more or less benign. They did ANA, C-ANCAs, ESR, CRPs, all of that was not very significant. And his blood cultures were negative. He did not have HIV. His CSF, though, did have a lot of red blood cells. White count was slightly increased. It's predominantly lymphocytes, and mycobacterial culture was negative. It didn't grow any bacteria on the culture. PSR for herpes was negative. He did have something called MOT cells were detected in his CSF. MOT cells are basically plasma cells with trapped IgMs. And there's a picture that I'm going to show later. Do you have any more questions?
The imaging studies?
There is imaging. So he had an EEG that showed a slow background rhythm, not really specific, but his MRI did show this, a little bit of this. Hyperintensity involving the frontal and the parietal white matter with further changes in the internal capsule and some patchy changes in the brainstem. And some patchy gray matter changes were present in the globus pallidus in both thalami. Do you have any tests you'd like? There's nothing on the blood purpose. They didn't do a brain biopsy. Thoughts?
Frame the case for them. Give them 2 cents.
All right, so I guess a Caucasian, 67-year-old Caucasian male who works as a photographer and recently travels, presented to the hospital with progressive neurological symptoms for the past 10 months, unsteady gait, memory issues, issues carrying out daily activities, and that's kind of more of his presentation. His past medical history isn't really significant in this kind of context, and his physical exam just demonstrated the neurological symptoms that he reported. CSF was sort of indicative, MRI was not really specific, and his EEG wasn't specific. But from his travel history, what can you think of?
Did he get bitten by any flies?
He probably got bitten by a lot of flies.
Is there anything that you could get bitten by a fly that might cause pot cells in your CSF?
Yeah.
Maybe.
So it's flies, not mosquitoes.
I think like some people have Googled this already, but they're afraid to say it.
Come on, Jan Joy, you know this, man. You're looking at me.
Sleeping sickness. Whatever, sleeping sickness.
It is sleeping sickness.
I've not Googled it, by the way.
I know. You don't know how to use technology, man. So it's human African trypanosomiasis. So they did a bunch of serological tests, and the antibody was positive for Trypanosoma brucei gambiense. And it's hard to get that from his history because specifically this kind of parasite, you can get it 2-3 years in the past, and only present now. And I'll be talking about that some more. So what is it? It's a parasite that's transmitted by a fly, basically. And it causes sleeping sickness. And it's purely an African disease. It's caused by 2 different types of parasites, Gambiense and Rhodense. There's actually a third one, but the third one's called brucei brucei. The lytics enzymes in our bodies just kind of break that down, so it only affects like cows and sheep and stuff. They don't have that enzyme. And it's transmitted by this little fly right here, which is called the tissy fly. There's also another Trypanosoma cruziae, which we're familiar with, and it's caused by the, I think, kissing fly? Yeah. And that's in South America. Causes Chagas disease. So the cycle of this organism, basically, it bites you, and it goes around your body, and I'll be talking more about that. But one of them has mostly a human reservoir, which is Gambiense, which is the one that you can carry for years, and Rhodense is the more acute one, and its reservoir is cattle. So where does it happen? So depending on the type of parasite, one is more central to West Africa and the other one's more eastern. So the countries that are particularly affected include the Democratic Republic of Congo, South Sudan, Central African Republic, which is here. In the West here, there was a lot. Now, I think Ghana, it's almost kind of eradicated in Ghana, just a little bit right here. And these all have Gambiense in this region. Rhodense is found in, I don't know why it's not dotted, but it's usually found in these countries in the West, in the East here, such as Uganda has both, Tanzania, Malawi, Zambia. These are the ones that have the Rhodense type. So a little bit about Sudan. So the diseases, this is the map before 2011. As you can see here, South Sudan is now an independent country. But before 2011, the disease was predominantly here in the south. And there's a lot of reasons why we don't really see this disease a lot, even in Sudan. Partially is because the infrastructure here is pretty bad. So the only cases we get to see are the ones that get all the way up to Khartoum. That's kind of where I went to medical school. Healthcare is kind of centralized in this country, so if they do need medical attention, they usually have to go there or to regional areas such as Damazin over here, which is also a big center and such. So I guess what we know about Sudan is the River Nile, which I've got the Blue Nile over here that comes from Lake Tana in Ethiopia, and the White Nile that arises from Uganda and goes all the way up to Egypt when it joins, after joining in Khartoum right here. And this is a pretty cool picture where you can see both of them meeting. It's the Blue Nile and the White Nile. This area here, right here, is called the Mugran, which is means joining in Arabic. And this is kind of Khartoum from above, and it just goes up. This should be like reversed, so it can go up. So the clinical manifestations, early infection. So there's two stages in this disease. Stage 1 when it's in the blood and the lymphatics, and stage 2 when it's in the central nervous system. And the progression from one stage to the next differs based on the parasite. So Gambiense can take years up until it gets into the central nervous system, where Rudense takes around a couple of weeks to months, so it's more acute. And what happens is you get bit, you develop this chancre, you get intermittent fevers, febrile episodes. And the reason why you get febrile episodes is because the parasite divides through binary fission. And every time it divides the glycoproteins that code it, it's like a 0.1% change. So by the time your immune system catches up and destroys the glycoproteins it recognized, there's a whole new other type of parasite that's in the blood, so it just keeps happening in that kind of cyclic manner. And symptoms include headaches, fevers, malaise, arthralgia, and like I said, they can correspond with successive waves of parasitemia and antibody production. When it enters the lymphatics, it can also go to the liver and the spleen, causing hepatomegaly, splenomegaly, and generalized lymphadenopathy. There's a picture so this is the chancre right here, and this is actually specific, kind of. It's called winter bottom sign, where the posterior cervical lymph nodes are enlarged, and you can see that in this disease. So the late manifestations is when it enters the CNS, and it's 100% fatal if untreated. Headaches, difficulty concentrating, difficulty completing complex tasks, personality changes, psychosis, and sensory disorders, tremors, and ataxia. Our gentleman had, I guess, difficulty completing complex tasks, and I guess the ataxia and urinary retention, which is not really said here, but it can happen as well. Meningism and focal neurological signs may occur, but are unusual. The hallmark of this disease really is the alteration of the circadian sleep cycle, where you're sleeping a lot. Daytime somnolence frequency develops. In kids, they can get convulsions. Deterioration gradually proceeds until the patient is almost in a comatose state. And when you're in that kind of state where you're sleeping a lot, you don't really eat a lot, so they become cachectic and malnourished. And they also have the risk of aspiration, so they develop nasty bacterial infections superimposed to their already parasitic infections. So how do we diagnose it? So you have to see it, basically. There are antibodies that you can detect that can give you a clue of what's happening, but you see it on a blood film, you take a sample from a lymph node, from the chancre itself, or from the CSF. And it's hard, so you have to really spin it to concentrate it so you can see it on a peripheral. And these are Mott cells. And they look pretty cool. Determine it based on, to determine the The type, because they look exactly the same under a microscope, you kind of use the geographical distribution, where this patient's coming from, the progression of the disease, and because that's important, because the treatment is different for each type, and depending on the stage, it's different as well. So you can have a patient with a parasite in his CNS but not having neurological symptoms. So once you kind of have a feeling that this is probably trypanosoma, you have to tap everybody to rule that out before initiating treatment. Yeah, undergo CSF. So the drugs that we have are, for early infection in trypanosoma brucei, you use pentamidine, suramin, and you kind of use these in big doses, especially when it gets to the late infection. You're using 200 milligrams per kg every 12 hours for 7 days. And you combine it with other medications as well. Milosporol was actually the only drug available for around 50 years. So we know how it works. It's not the best drug, and I'll be talking about that some more when I get to the side effects of these medications, because that's kind of why I wanted to present this case. The side effects are devastating. And if you look at it, milosporol is a trivalent arsenic compound. So it's arsenic. You're basically giving these patients arsenic, and 10% of them get arsenic encephalopathy. The way you can fight that is by giving them steroids, which cuts that number down to 5%, but you're still giving arsenic as a medication. Side effects include hepatotoxicity, peripheral neuropathy, paraplegia, cardiac arrhythmias, and albuminuria. For suramin, I think this is the least benign one, the most benign one in these medications. It causes some renal impairment, which almost every other drug we give here in the hospital does. Some dermatitis, neurological toxicity, and pancytopenia. The third one, eflornithine. So its side effects occur in 40% of patients. It includes vomiting, abdominal pain, dizziness, arthralgias, hearing loss, seizures, rash, alopecia, and bone marrow toxicity. And these aren't like the type of side effects that you watch on TV and it's just mentioned so they don't get sued. These actually happen to patients. So when you present this to a patient, do you want to die or do you want to get this? It's kind of hard to pick because the illness is going to kill you, but the treatment can almost kill you as well, which is depressing. A little bit about the neglected tropical diseases. So Chagas disease is also one of them. Human African trypanosomiasis is one of them. So these are diseases that were, this was in the 2017 World WHO categorization. These are diseases that I guess simply you can say that the world isn't really paying much attention to. And it's not just a moral kind of complex. It's the fact that we can't really reach patients that have these due to conflicts. And I'll be talking about that a little bit as well. So conflicts, infectious disease, and sleeping sickness. So the current of HAT often reflects war, civil unrest, lack of reliable presence of state authority, and the difficulty is in estimating the incidence of this disease due to the remoteness of the affected regions and the focal nature of the disease transmission. So let me go back to the map. Okay. So most of these patients present from areas where they rear cattle or they work in farms. They don't really have hospitals. I remember we had a rotation where we went, it was like a week-long rotation somewhere, where was it? It was somewhere here near Al-Lubayl, where we had to kind of see how public health is run, the hospitals and such. And the PCP there was an internal medicine trained that was doing everything. He was the OBGYN, he was the surgeon. And he would say that he basically, with the resources he had, he'd do what he can. And then he'd get to a point where he'd tell them to come up here, because most of the tertiary hospitals that can manage these patients are in Khartoum. But patients would be so far gone by that point that they prefer to just stay at home and be with family. Because going to Khartoum isn't just going to the hospital. There's a lot of cost involved where they're going to stay for the family. The medication, everything in Sudan related to medical care is kind of out of pocket. So paying for medical attention is expensive. And most of these people don't really have the resources to do so. And an interesting fact about Sudan when it comes to medical care, even in Khartoum, the vast majority of patients go to pharmacists because antibiotics, you don't need a prescription to get anything there. So they go to the pharmacist, explain their symptoms, and then they get medications. So most of them are not even treated adequately with labs or anything like that. And some of them just do that, which is depressing. So this is a graph that kind of shows how sleeping sickness is affected in times of war. So it was discovered around 1897 by this Scottish doctor called something Brucey. He's the one that discovered brucellosis as well. I guess he really liked cows and sheep and such. So the first case was reported in Uganda, at least. This was where? Yeah, this was in Uganda. In the early 20th century. Here, there wasn't really any treatment at this point. I think the first drug that was discovered was in the 1920s. So all of these were just fatalities right here. And around the World War II, it kind of bumped up a little. And then when most of these African countries got independence due to the civil unrest and like there's some overthrowing some governments over here, a massacre over here, and another overthrowing of a government here where the numbers just skyrocketed. And an interesting point, in, what was it, 1999, there were 45,000 cases that were reported to the WHO, but they were saying that the actual number was 10 times that due to the low cases in reporting. And 100,000 people probably died unnoticed or not reported to the WHO at all. That number did significantly decline. By around 2013, there was around 7,000 cases that were reported, but it's also a kind of unreported illness, so you can't be sure if that's the actual number that's out there. So prevention, control. So it's hard to prevent it because it's kind of hard to detect, especially in rodentity. There's basically two ways to prevent it: surveillance and vector control. So in surveillance, in Gambiense, you can kind of have an edge because you can screen people. This disease stays in your body for a couple of years. So if you screen a lot of people and treat them when they're in the early stage, you can control that in some sense. But when it comes to rodentity, you have to control the vector itself because it's such a rapidly progressive disease. By the time you see the patient, they're usually at stage 2, and you have to go aggressive in their management. In surveillance, humans are a significant disease reservoir for Gambiense, and like I said, it was mostly screening. And vector control, which is the one you do for rodentity, it's usually done with traps or screens in combination with insecticides and odors that attract the fly. Reducing the reservoir of infection is more difficult for the subspecies since there are a variety of animal hosts. So it's hard for rodentity to kind of surveil cattle, cows, sheep. It's hard in that kind of sense. And this is just a gentleman right here setting up a trap to kind of catch these flies. So advice for travelers. So the WHO and the CDC kind of give us some tips on what to do. Wear long sleeve shirts and pants of medium weight. It can't be too thin because the fly can still bite you through it. So you have to wear, it's kind of hard because it's really hot there. And they're basically telling you to cover up and wear something thick, but I guess that's what we can do. You can inspect your vehicles before entering them. The flies are attracted to the motion and dust from moving vehicles, which is very particular for them. Avoid bushes. So the tissy fly likes bushes. So it stays there. And they're less active during the hottest part of the days, but that's kind of when people there go to kind of relax and sit under a tree and disturb it and get bit. Using insect repellents can help, but it's not been proved to be particularly effective against the tissy fly itself. But they will prevent other insect bites that can cause different illnesses, because that's kind of what happens. So the take-home points for this presentation, I guess, is what is human African trypanosomiasis, the difference between the two parasites, including the epidemiology, where you find Rodentia morelli in the eastern part of the continent and Gambiense centrally and more western located. Treatment differs based on the stage and the type of parasite that you're dealing with. The risk factors and preventive measures. I guess the risk factors is conflict. Areas where refugees are, immigration, because they go from this camp to the next. Like, why does Uganda have the two types? Because it has refugee camps for refugees where they come from different areas and they all meet there. So it's one of the few countries that actually has the two types of parasites. And a little introduction to neglected tropical diseases. I wanted to divulge a lot into neglected tropical diseases, but I guess due to time restraint, we'll have to leave that for another day, sorry. And these are the references that I kind of used. There's a cool case. This one, the civil conflict and sleeping sickness in Africa, and that was a really good one. It was long, and it took time to read, but it was good, and it gave me that graph. And this is the case report that I used. If anybody's interested, you can just ask me, and I'll text you the link to it. And thank you.
So mine is a little more familiar to everybody. Not as interesting, but it's a great way to start the presentation, right? So my name is Dr. Caitlin Wool. Most of you know me. First year resident. So we're just going to jump into my case. So Mr. Z, he's a 49-year-old African-American male with no known past medical history who presents with several-month history of generalized fatigue. He says the fatigue started gradually, and now he's too fatigued to do basic activities of daily living. Review of systems is positive for occasional numbness and tingling in his lower extremities, snoring, daytime sleepiness, increased thirst, frequent urination, and unintended weight loss. The rest of the review systems is negative. He's not established care with a physician in the past, as he is uninsured. So, past medical history, none. Medications, none, obviously. Family history, mom had type 2 diabetes and hypertension. Dad died from a heart attack, unsure of prior medical history. Social history. Lives by himself. He smokes a pack of cigarettes a day and has a 31-pack-year history. He drinks about 3 12-ounce beers a day, currently unemployed. He notes that his car stopped working, and he was not able to make it to work on time, so he lost his job, and he's completed high school education. And then for his physical exam and labs, I'm just going to go over the highlights. Blood pressure was elevated, 178/90. We do the repeat manual after he's been sitting for a while, still 172/90. BMI 35. He is morbidly obese African-American male. The other pertinent is he has decreased sensation in his lower extremities up to ankles bilaterally. And then his pertinent labs, his glucose was 250, hemoglobin A1C of 10.5. He has high cholesterol, 250, with an LDL of 176 and triglycerides of 205. BNP and CBC are normal. So this is obviously very classic and straightforward. Most of our patients aren't like this, but this should sound familiar to a lot of us because this is a lot of what we see here just in the hospital or in the clinic. And so As most of you probably know, I'm from the South, so that's why I kind of picked this bread and butter case, and to highlight kind of some of the things that I've seen as I've traveled through the South, plus and just some observations that I've made. So just here's his case, highlights. So he's got the snoring in the daytime sleepiness, likely has sleep apnea. He has class 2 obesity with a BMI of 35. He has high blood pressure, diabetic, hyperlipidemia, a 31-pack-year smoker. If we could just stop there, our jobs would be a little bit easier. And if, he was super motivated, our jobs would be really, really easy, because we could be like, hey, listen, let's work on diet and exercise, and in the meantime, we'll give you some medication and treatment, but with the ultimate goal of seeing how much we can get off. We could send him to the sleep doctors. They could do sleep apnea, which would help with his blood pressure, would help us with all these things, but he's uninsured. And that's a kind of a common thing that we especially see at Dodson and here at Erlanger. So, like I mentioned earlier, I just kind of roamed around the South, moved for my dad's job. So I was actually born in Georgia, moved around in Georgia a little bit, then moved up to Connecticut, lived there for 2 years, came back to good old Mississippi, lived there for 8 years, and graduated high school. My family decided to head back to Georgia when I went off to college, but I stopped in Alabama. Was there for 3 years for college, then came back to Georgia, did my medical training in Georgia. Now I'm parked in Tennessee for the moment. So as you can see, I have lived in very healthy states. No, that's not what that means. So the state health rankings, what that is that's a combination. It's a score that is an average of something called health outcomes and health factors, or health behaviors. So health outcomes are, they're both objective and subjective. Objective, it looks at cardiovascular deaths, it looks at diabetes, looks at life expectancy. Those are kind of the things that they measure. The subjective part of that is they too look at kind of your quality of life. So it kind of combines the quantity and quality of life. So quality of life would be, how many sick days do you perceive, those kinds of things. The health behavior, I like that. Health factors can also be a term for that. I like health behavior because it kind of makes me think of 2 of the 4 factors that go into that. Health clinical factors. So, how many PCPs or how many mental health professionals are within a state? How many rehospitalization or unnecessary hospitalizations are there? That's kind of the clinical aspect of that. For the behaviors, that's what people do, or don't do. So in the case physical inactivity or smoking or excessive drinking or drug use, that's part of that. So that's 2 components of health behaviors. The other 2 components are policy, so looking at how much, like your immunization records and all that stuff, plus how much you spend on public health, how much funding there is for that. And then the 4th factor is social and environmental. So kind of what is available. I'm blanking on some things there, but really, when I think of environmental, I think of the main thing I kind of think of is what food structure do you have? What other things for environmental would be, or pollution, those kinds of things. So this number that's up here is the average, and it's out of 50. So I have lived in pretty much the bottom 40 for most of my life. Georgia is 39, so it's like teetering there. I think it's been in the 40s in the past, so it's making progress. But the healthiest state I've actually lived in was Connecticut. That's actually 3rd right now. I didn't put that up there. But and then Mississippi was 49th, and that was kind of a pride thing, honestly. We were all like, well, if it wasn't for Mississippi, all the other states wouldn't have someone to compare to. Like, at least we're not Mississippi. Anyway, but so I haven't lived in the most healthy states, and so again, you know, that kind of has skewed how I view health. In that we've talked about, you know, I just noticed on rounds and stuff, especially at the beginning of this year, people were the doctors would ask, are they overweight? And I'm like, huh. And because my vision of overweight is, well, they're overweight, but they're not like morbidly obese. But this person is like morbid obese based on the numbers. So again, just like being skewed. And then, you know, traveling across the United States this summer, just kind of seeing how different, you know, I didn't practice healthcare there, but just seeing just the difference in activity and what is available relative to what I've grown up in. It was a good experience, and it just made me aware. So I'm not going to go through all of this, but basically this is just, you know, when I was asked to do this, I was thinking, like, let me think about the United States, let me think about where I've lived, and then let me kind of hone in on my home state. So this is just kind of, I wanted to kind of get a snapshot of how everything compared: Georgia, Tennessee, Mississippi. I didn't include Alabama in here. But as you would expect, because they're kind of towards the bottom 50, they're pretty bad at a lot. They're lower than the average United States. So life expectancy is lower. The under 5 mortality is higher, with Mississippi being the worst, and Georgia's pretty high up there, but they're improving on that. The top 5 causes of death are the same throughout, and they're actually in the same order, except for Mississippi, where lung cancer bumps up to number 2 versus number 3. It switches with Alzheimer's. And then the top 5 risk factors, which again, I highlighted this because this is what our guy has, this is what a lot of our patients have. They matched up, very similar. So now I'm kind of honing in on my state. I consider myself from Georgia. I've lived there kind of in pieces. And so, does this thing show up on here? So my family lives here in LaGrange. Atlanta's here. So we live right here. That's where my parents live. So I came over here with them. Then I actually graduated from Mercer. So I didn't finish college in Alabama. I finished up in Mercer. So I was in Macon for a while, but I didn't really consider that a part of kind of what I looked at in regards to just the health of the cities that I've lived in. Then I moved over here to Augusta, that's where I did medical college of Georgia, graduated from there. I was there for 2 years doing the book work that you do for medical school. And then I migrated over here to Rome, Georgia, which is where I was for 2 years doing clinicals. And then obviously now I'm here. So I have family. All my family and future family live in the state of Georgia. My mom's family lives in Carrollton between Rome and LaGrange. My dad's family lives in Warner Robins, or between Athens and Augusta. And then my fiance's family, they live in Atlanta. So again, that's why I was really interested in Georgia, because that's where most of my family, or that's where all my family is from. So just kind of some overall health highlights for Georgia. Georgia is ranked 39 out of 50, which we discussed. But the average of those two numbers, the health outcomes was 35, the health factors were 44. So the health factors is kind of what pulled us down. But us and the health outcomes helped us a little bit. In the past 6 years, obesity has increased, but they have children in poverty has decreased, which is a positive. And then the other positive is they're increasing the mental health and primary care physicians. They're still ranked 46 out of 50 and 42 out of 50, but they are improving. So just looking at, so I looked at the 3 counties that I've really kind of practiced medicine, or where my family has been affected by medicine, particularly my dad. So Troup County right here is where my family lives. Again, this is LaGrange. Richmond County is Augusta, and Floyd County is Rome. And so I looked at kind of how, and this is kind of what I expected. I kind of expected LaGrange to kind of be in the middle. This is out of 159 counties. I expected Rome to be a little bit higher up and everything, and I expected Richmond County to actually be lower, even though there's a lot of health care provided there. I just thought that this is kind of what I expected in overall health outcomes. So again, just remembering that's, the quantity and quality of life, and the health factors include the social and environmental policy, the behaviors, and the clinical resources. So we've talked about this. We talked about this for internal medicine. We talked about this kind of a little bit at our retreat, is the social determinants of health. And I think this is really interesting because even if we had a perfect system where we could prescribe everybody all the medicine and get them into C, we still wouldn't have like the perfect outcomes, because people aren't just like science are not in a beaker. There's other things that affect what they do and how healthcare goes for them. And so there's 5, health and healthcare over there in the green. That's where we are. And so that's just a component of this whole kind of taking care of a person, I guess, circle. Social and community context plays a role. So again, I think this is kind of where your cultural beliefs and those kinds of things come into play. Education, so high school, college, what you know about health is in this education aspect. Economy and stability, so what is the employment rate, unemployment rate, and the neighborhood and built environment. This is where those the term like food desert comes in. And do they have the resources available to them, like grocery stores, or I would say even transportation could probably go into this, the ability to get to their appointments on time, or the ability to get to appointments or get around. Also the thing I think about is just being a runner, like where can you go run? Where can you go do physical activity outside? The ability to do that, what's available. And so I kind of broke this down. I've collected a lot of data. I kind of tried to pick out some important stuff and examples just from Georgia, Troup County, where my family lives, Richmond County, where Augusta is, and Floyd. So primary care physicians, Floyd does the best. There's one physician for every 770 patients. For Richmond County, there's one physician for every 1050. So those two are better than the average, or better than the state of Georgia, which is not great. But then Troup County is 1890, so almost 2,000 patients per one physician. Uninsured is the highest in Floyd, and actually the lowest in Richmond, and it's all kind of better than the state as a whole. So moving on to social and community context, so this is like children in single-parent homes, and then also, residential segregation. Richmond County, just to highlight kind of the outlier, I guess is the best way to say that. Richmond County, 54% of the children live in single-parent homes. So again, that means that they probably have less resources to them compared to patients who live in both parent homes. So that's just an interesting. Oh, I'm going the wrong way. Sorry. A little tired. Education. High school education was about the same throughout. Floyd actually had a really high education. 92% had a high school education, which I thought was interesting. And then some college, again, was kind of the same throughout. Nothing really. It was all lower than the average, than the whole state as a whole, but I really wasn't surprised by that. I keep going backwards. Economic stability. So here's some unemployment, children in poverty, and food insecurity. And so these are some things that I thought were interesting, as Richmond did not do great. Unemployment was 5.9% in Richmond. The average for Georgia is 4.1%. Children poverty was 35%, which that correlates with that number that I was talking about earlier. Children in single-parent households was 54% in Richmond County. And then also food insecurity was high as well, 23%, 15% for the state of Georgia. So not great numbers. Unemployment, children poverty, food insecurity, and we'll talk about, we'll flesh that out a little bit more on the next slide. And then the food environment index was 5. So the food environment index, I'm blanking on that. The limited, let me move to the limited and then I'll find out. I think I wrote it down. But the limited access to health foods, that's the kind of the similar thing that I was talking to you about, the food deserts, in that do they have, what resources do they have around them? Grocery stores that sell healthy food. Access to exercise opportunities were kind of the same throughout. I was actually kind of surprised that Floyd was lower because they have Berry College there that has a bunch of trails and stuff, but maybe they weren't factoring that in. And then there's a severe housing problem in Augusta as well. So again, Augusta is really poor on neighborhood and built environment. They're really poor on economic stability. So it's unstable economically, and it's kind of, and then too, I would say it's unstable in neighborhoods and built environment. And what I did write down, did I write down the, I did not. I apologize, I don't know what the food environment, I thought I wrote that down. I knew it a few days ago, I apologize. So these are kind of the 5 factors that go into social determinants of health and kind of affect our patients. We deal with the green aspect, but as you can see, there's a lot of other aspects, and they're all equally important. One circle's not bigger than the other. So kind of to talk about just some stories. So this is Richmond County. The top picture, that's Medical College of Georgia. That's a new building. And so that is located pretty much downtown Augusta. Right beside that, there's 3 hospitals. There's the University Hospital. I don't know the name of it anymore because they keep changing it. There's the actual, so there's the Medical College of Georgia Hospital. Then there's actually a hospital called the University Hospital. And then there's another, I just blanked on that name, but I just had a second go. But there's 3 hospitals right beside each other, downtown Augusta. Not only that, but there's a dental school. You can kind of see it right here. That's the dental school. And then there's physical therapy, nursing, all that stuff there. And so with this, you have, y'all are all in medical school, you know how many free clinics. And I was thinking through this, there was at least 6 free clinics that we had. Probably closer to 10, but I can name 6 pretty quickly. And I was a part of at least 3 of those at one point. And then here's the river trail, or the river walk, the actually canal trail. And then there's a river walk as well. This is really close to downtown. It's a 5-mile trail, one way. Very nice, good place to exercise. This is community. This is Christ Community Health Services. So this is for people who are uninsured, or so it's a scale pay, and this is a big. This serves a lot of patients. And so right here, this is called the Old Widows Home. It's from, I believe it's around the Civil War, but this is right, if you just walk not too far, you're pretty much in the worst part of Augusta, the poorest and worst part of Augusta. This down here is the clinic. And then when I was working there, they just had this. They were in the process of raising money to finish the second and the third floor. These were going to be dental clinics run by the dental students, and then they were also going to have physical therapy and nutrition available here. And I think they have finished that because it's been a few years. So I did an internship here, and that's where I was first exposed to global and community health. And while I was there, we had to do 2 activities the first week that we were a part of this program. So the first activity was we had to ride the bus. We had to ride the bus to what we called Murder Kroger. It was not too far from the medical school. It was again, the medical school is not in the best part of town. We had to go there and come back on the bus. It took us 3 hours. I could have ran that in an hour. I could have ran that in less than an hour. I could have walked it probably in an hour. It was not far. It was a few miles. But, you had to have the right change. You had to know where the bus stop was. And so the point of that was to say, here's some barriers to health. There's not just it's not just hey, give them the medicine and provide them with the health care. This is why they were late to their appointment. This is why they didn't get here on time. This is why they couldn't make their appointment that we set up for them. They had a few colonoscopies that they could give out to everybody here. This is why they showed up late to their colonoscopy, because they didn't have a car and the bus was off. We sat at the bus station for 5 minutes because the guy was just chatting with his friend. And then we were like, okay. So, they did not have and so that was a new perspective for me of I didn't even think about that. But they don't have a car. They can just hop in and get there on time. So that kind of changed, that kind of made me more aware of these social determinants of health. The second activity that we did was we walked from the clinic to Paul's IGA. It's right down just not too far down, 2 doors over. And we were given $20, and the goal was to make a healthy meal for four people. So we walk in, and we're like, okay. So as we're walking in, this is the only grocery store that's within Kroger, like I said, was about 2 miles down the road. So this is the only grocery store that was there in this area, the poorest part of Augusta. So we went in there. The fruits and vegetables were colors that I didn't know that fruits and vegetables could be because no one had them. When we first walked in, it looked like a convenience store. There was junk food, and that was readily available to you. We had to kind of find the healthy things, and it was really hard. When we tried it, we were like, we'll do chicken. It was chicken wings with skin on it. There really wasn't much chicken breast, and it was really expensive. I think we ended up $18 is what we calculated. And then you have to think about, did they have pots and pans to cook this, and just other factors that we had never thought about. So again, this introduced me to the idea of food deserts, and because kind of my go-to things when people come in and they don't have insurance is eat healthy and exercise. Well, that's a lot harder than you think, because again, this is the worst part of Augusta, so it's not safe to run. It's not safe to be out. He told us a story about he did have some patients form a walking group, but the other people in the community didn't like it, and so they were kind of bullying them, and they stopped the walking group. So again, these are things that I didn't even know. And then you had this Kroger down here, which was the closest thing. The next Kroger and Publix were at least 4 or 5 miles down the road. They closed it. And so now, they closed it a few years ago, and so now they don't have anything except the Paul's IGA and convenience stores. And so this is just kind of, and what's interesting is you have all these resources. I started out with the Medical College of Georgia up here because you have all these free clinics. You have Christ Community here. Richmond County ranks 21 out of 159 in the state of clinical, what I was talking about is the clinical factors, which includes PCP and mental health providers. So they have the medical resources there available, 21 out of 159 counties. And yet the health outcomes were 126-ish, and the health factors were 96. So that's there's a huge gap between, you have this, we talked about the healthcare piece, which 21, again, that number of 21 out of 159 in Augusta, and yet it's 125 in the state. And that's because these neighborhood and economic stability factors are really weighing down what that healthcare piece of this. So I know we're pretty much out of time, but basically what I was just going to point out is for the patient's case, so tying this back in, our patient's unemployed, he's uninsured. He has limited access to healthy foods if he's in Augusta. Limited education, he's high school. Limited access to clinical care. Again, Augusta had better, if he was in Augusta, he would have a little bit more access to clinical care than probably most. And then the public transportation, which I got a taste of. And so what can we do? We talked to him about smoking cessation, which is easier said than done. Most places have Georgia had the Ready to Quit, so they would give you some free stuff to help you quit. Nutrition counseling, that's easier said than done as well. Something that I have found is, hey, can you substitute water? I mean, most people can have access to water, and it's free or they're already paying for it. And then just cheap medications and supplies, which is what this is up here. The Lilly Cares Foundation. So I found Georgia Public Health actually had a good website, and I was kind of poking around on there, and you can type in what your patients need or like their descriptions, and they'll tell you like, here's insulin, here's this, here's how you can get that. RX Hope is something similar. It's kind of a charity-based situation. And so that's just kind of my story of how, I grew up kind of in an unhealthy area, not really aware of the social determinants of health and how that affected other people. And then just kind of being exposed to that while I was in medical school. And then hopefully and then the goal is to get more exposure as I go through this program and complete residency and work at Dodson Avenue in those venues. So these are the resources I used. County health rankings and roadmaps, that was just really interesting. I like data, so it was interesting. But that's it.
Thank you, guys. Because of time, I think if there's questions, you can just come up and talk to myself or Drs. Will or Abdel-Gadir. But thank you guys for coming. Go ahead and eat some more food on your way out. Or take some to your colleagues. I think there's probably some left. Thank you.